DESTINY study, because I think this is very important one for many reasons. Over the last year, over the last few years, we start to realize very clearly and see very clearly that colon cancer is not one disease. Colon cancer is a family name, and each subgroup, they might have their own unique feature or characteristics that perhaps will define a better way that defines the treatment choice or define how we should treat them. And we start now to realize that there are many targets in colorectal cancer we should look very closely at. Obviously, we just talked about MSI high. We talked about in the recent event about BRAF V600. But one of the very important target is also HER2. HER2, obviously, it's something we hear about a lot in breast cancer, but it's actually making its way to colorectal cancer. DESTINY study, that's kind of the umbrella and we started to look at DESTINY in upper GI, DESTINY in colorectal cancer. So DESTINY-CRC01, that's the study looked at using T-Dxd in patient with HER2 expression metastatic colorectal cancer. And this ASCO 2021, we heard the final result from the phase 2 multicenter open label. I think most of our oncologists now in GI start to get more and more familiar with TDxd because of the recent approval in upper GI. But this is a antibody drug conjugate that designed to deliver an optimal anti-tumor effect with that just amazing technology. So you have the antibody, you have the warhead, you have the linker, and very much that antibody will go and get attached to the receptor and then go inside the cell, and then the linker break, releasing the warhead and start to have the cytotoxic effect. The DESTINY-CRC01 study design, as I mentioned, was like an open-label, multi-center phase 2 study that included colorectal cancer patient. But it's very important to highlight those inclusion criteria. Patient had to have, the tumor had to be RAS and BRAF wild type, so they did not include RAS mutant tumor. And also, they had to have at least 2 lines of therapy, so 2 or more prior line of treatment. And even they allowed patients who had prior treatment with other anti-HER2 agent. So in essence, this like very heavily pre-treated patient. Some of them even were treated with anti-HER2 therapy. And they had like 3 cohorts. Cohort A was a HER2 positive cohort, which were defined as IHC 3+ or IHC 2+, but ISH positive, and those were about 53 patients. And the primary endpoint was overall response. Secondary endpoint was progression-free survival, disease control rate, duration of response, and so on and so forth. And when you look at the patient characteristic for the cohort A, also I want to highlight this because 80% of patients had left-sided tumor, and about 11% had right-sided tumor. Our group actually did some work before, and we were able to see that or show that the HER2 amplification is more condensed and more frequently you see it in the left-sided tumor. So that's also something I think we should watch for. It's not just tumor location, it's like what is the marker that associated with that tumor location. For that cohort A that had 53 patients, IHC 3+, most of them had 3+, so 75%, about 25% or 24% had IHC 2. 2 plus. Almost everyone, so 100% had irinotecan, all patients had oxaliplatin, all patients had Trastuzumab or Panitumab, and about 75% had BEV, and 30%, which is, I think it's also was interesting to see, 30% of patients had prior anti-HER2 therapy. So as I mentioned, those like highly pre-treated patients. And I'm sorry, and 100% had fluorouracil. So everyone got FOLFOX, FOLFIRI, Xelox, so BEV, Trastuzumab, and HER2. Some of them had HER2 antibody. In terms of efficacy result, there were no complete response, no CR was seen in that cohort A, but about 45% had partial response, and 37% had stable disease, adding to a disease control rate of about 83%, with median duration of response about 7 months. Me personally, looking at this result, I think it's very, very striking, because all of us treat colorectal cancer patients in the refractory setting after they get FOLFOX and FOLFIRI and biologics, and we know how they do. We know how hard to achieve a response and how hard to control to achieve disease control rate. But here in this setting, yet you see 83% disease control rate in this heavily treated patient. And when the waterfall plot was presented, again, you can see a very impressive waterfall plot, and more focus driven by the IHC3 plus, but also you could see someone with IH2 plus. Not only the disease control rate was impressive, but also, which I think more important, the tail, like the long-lasting response, the durable response that you see with those patients. You were able to see this in several of them. Also, when you look at progression-free survival and overall survival, I think it was very impressive in that kind of setting. Median overall survival was 15.5 months in the IHC3, and progression-free survival was median 6.9 months in IH3 plus. So just to highlight here, I think it's very important for all of us in our practice to have a very close relationship with our pathologists and histopathologists, because you can see there is a difference between 3 plus and 2 plus and obviously 1 plus. And also, we have to have a better understanding why that's important, because the benefit will differ. One of the important element also, or finding we saw in the study, it is not just the impressive and striking efficacy among those highly pretreated patients, but also was very important that was a special interest adverse event. So adverse event of special interest, particularly that the interstitial lung disease, or ILD. ILD was seen about like 9.3% in patient in this study, and also the other clinical trial we saw ILD happening. So the reason that's important, because yes, it's not too common, but it's serious adverse event, and it's very important for all of us to keep eye for it and have low threshold for looking after it, because at least it's going to start maybe with cough and shortness of breath. And sometimes it's even early on, it's asymptomatic. So clinician, nurses, infusion center have to have a very low threshold to detect this and keep eye on that. And I would go even farther than that. I would say patient education also is very critical here, because we should educate our patients that this is possible side effect, and you have to be aware of it. And you contact us, please, if you experience any of those symptoms. And I have to admit, this is a challenge, because in the COVID era now, hopefully that should be over soon, but in the COVID era, a lot of patients also coughing and having shortness of breath and so on and so forth. So I'm saying it's something we need to watch for and have a hopefully early detection for, because I think it's important to catch it early. And there is very clear guidelines of how to treat it and how you should stop the drug and when you should initiate again or just discontinue. But I think just recognition is a message here. I have to say I'm jealous from our breast oncologists, because they have been using that drug for a long time, and we just in colorectal cancer we start to introduce it. But I'm also very excited because it's giving us more and more option now. And as I mentioned before, I think the theme, not just in this ASCO, but I think in the last few years, that we doing a better job in better understanding the biology of the disease. And we don't treat every patient as one. We actually look at different features and with the long, durable, lasting response. And I hope to continue to do that, discovering more therapeutic option. We heard recently about the KRAS G12 inhibitor, and in fact, it was released in the US. But I hope more. That's a very exciting time for us to be in the oncology field.